this video, we will discuss miscellaneous acquired eyelid disorders. These include conditions that do not fit into ptosis, entropion, or ectropion categories. Eyelid varices are venous lesions and should not be mistaken for pigmented or solid tumors. An eyelid varix is a venous malformation of the eyelid. It may be isolated or associated with orbital varices. Eyelid varix is a dark red or purple subcutaneous lesion. It is soft and compressible unless thrombosed. The key diagnostic feature is increase in size during valsalva or dependent position. It may be mistaken for nevus or hemangioma. The management is usually observation. Simple excision can be done for cosmetic or diagnostic reasons. Always consider orbital communication before surgery. Unrecognized orbital extension may lead to significant bleeding during excision. Dermatochalasis is redundant eyelid skin due to age-related changes. It commonly affects the upper eyelids and is often discussed with pseudotosis. It causes a false appearance of ptosis without true levator dysfunction. Floppy eyelid syndrome is an uncommon but frequently overlooked condition. It usually affects obese, middle-aged or elderly men and is strongly associated with obstructive sleep apnea. It is characterized by excessively lax upper eyelid, rubbery soft tarsal plate, and easy spontaneous eyelid eversion during sleep. Chronic nocturnal eyelid eversion leads to conjunctival inflammation and ocular surface diseases. The clinical features are upper eyelid is easily everted, redundant upper lid skin, superior tarsal papillary conjunctivitis, and chronic irritation, discharge, and watering. Papillary conjunctivitis is a key sign and is often severe. The management options are treat the associated obstructive sleep apnea, lubrication and nocturnal lid protection in mild cases. Definitive treatment is upper lid horizontal shortening, pentagonal resection, and or lateral canthal tightening. Surgery aims to restore lid rigidity and prevent nocturnal eversion. Eyelid imbrication syndrome. This condition is uncommon and often misdiagnosed as chronic conjunctivitis. Here, the upper eyelid overlaps the lower lid during eyelid closure. The lower lashes irritate the superior marginal conjunctiva. It may be unilateral or bilateral and is often associated with floppy eyelid syndrome. It may also follow lateral tarsal strip surgery. Always consider imbrication syndrome in patients with superior marginal conjunctivitis. Upper lid retraction is a sign and not a diagnosis, and it requires etiological evaluation. Here, the upper lid margin is at or above the superior limbus, and it produces a scleral show. Thyroid eye disease is the most common cause of upper eyelid retraction. Other causes are neurogenic, mechanical, congenital, and miscellaneous causes. The neurogenic causes of lid retraction act through abnormal neural input to the levator muscle. Examples are contralateral ptosis, unopposed levator action due to facial nerve palsy, third nerve misdirection, Marcus Gunn jaw winking syndrome, dorsal midbrain syndrome, Parkinsonism, and sympathomimetic drugs. In mechanical and congenital causes, mechanical restriction or excessive levator pull leads to lid elevation. The causes are post-ptosis surgery overcorrection, scarring of upper lid skin, Duane retraction syndrome, Down syndrome, and transient eye popping reflex in infants. The management of upper lid retraction lies in treating the underlying cause. The choice of surgery depends on severity and residual lid tightness. Mild cases are treated with Muller muscle recession, and moderate to severe cases require levator aponeurosis recession. Lower lid retraction is commonly seen in thyroid eye disease. It is characterized by inferior scleral show. It may be physiological in large eyes. It is commonly involutional or secondary. Blepharochalasis. It is a rare condition with recurrent painless eyelid edema. It typically begins around puberty. Repeated episodes lead to permanent eyelid structural changes. The clinical features are recurrent eyelid swelling leading to progressive thinning and wrinkling of eyelid skin. Cigarette paper appearance is a characteristic finding. It may be associated with ptosis and lacrimal gland prolapse. Management is conservative during active phase. Surgery should be delayed until the inflammatory phase has settled. Correction of ptosis and skin redundancy are attempted. Some exam relevant points are varix enlarges with Valsalva. Floppy eyelid syndrome is linked to obstructive sleep apnea. Upper lid retraction most commonly is due to thyroid eye disease. Blepharochalasis presents with recurrent edema in young patients.